Hello, my name is John Abdulnor. I am a PGY1 internal medicine resident at Case Western Reserve Metro Health Systems in Cleveland, Ohio. Today I will be discussing a case report on PDL1 inhibitor-induced cardiomyopathy. And so, introduction for this case. So the use of immunotherapeutic medications for cancer treatment has grown in popularity since they were approved by the Food and Drug Administration back in 2010. Specifically, programmed cell death 1 inhibitors and programmed cell death ligand inhibitors have shown efficacy in halting the progression of neoplastic cells by exploiting the immune system's capability to seek out and kill cancer cells. PD1 and PDL1 inhibitors have led to improved morbidity and mortality in patients with advanced cancer. However, recent studies have examined the consequential side effects of these medications. Specifically, cardiac toxicity will be discussed, and what it may mean to patients who undergo therapy with these agents. And now for the case presentation. A 66-year-old African-American female presented to our ED with chest pain. The chest pain was retrosternal with radiation to her back and was relieved when she sat forward. However, it was exacerbated with deep inspiration and coughing. She has past medical history of non-ischemic cardiomyopathy with a recovered ejection fraction, as well as squamous cell carcinoma of the right lung status post-surgery, and was treated with durvalumab, a PDL1 inhibitor. She also has coronary artery disease, as well as hypertension, dyslipidemia, and active tobacco smoking. Her vital signs in the ED were unremarkable, and as well as the exam was unremarkable. They did a CT of her chest to rule out aortic dissection, and there was no cardiopulmonary acute processes. Her blood tests and serial troponins were negative. However, her CRP and ESR were elevated. Given the atypical chest pain and cardiovascular risk factors, a left coronary angiography was done, which showed 60 to 70% eccentric stenosis of her anterior descending artery, which was unchanged from her prior angiography. Therefore, no coronary interventions were performed. An echocardiogram was done, which showed a left ventricular ejection fraction of 40% with no segmental wall motion abnormalities or significant valvular pathology. However, given her history of malignancy, a cardiac MRI was done, which showed a left EF of 50% with a small pericardial effusion and mild aortic valve sclerosis. However, there was significant late gadolinium enhancement in the mid-wall of the anterior wall as extending into the basal inferior wall. These findings were consistent with myocarditis, and in the absence of other risk exposures for myocarditis, this was consistent with PDL1 induced cardiotoxicity. The patient's cardiomyopathy was treated with GDMT, guideline directed medical therapy for heart failure. Steroids as well were used, as she was not in fulminant myocarditis. After collaboration with the oncology team, it was decided to not prescribe her the PDL1 inhibitor in the future. She was discharged with appropriate cardiology follow-up appointments. Her symptoms and left ventricular EF subsequently recovered. The PD1 and PDL1 pathways have been shown to be an important mechanism in preventing immune-mediated myocarditis and cardiomyopathy, secondary to autoimmune diseases. Therefore, when the pathways are inhibited with immunotherapy for the treatment of advanced cancer, the incidence of cardiovascular events increase compared to the regular population. The majority of patients develop the symptoms of cardiac toxicity soon after starting treatment. However, the etiology of immunotherapy-induced myocardial injury is not yet well established. In conclusion, immunotherapeutic medications, including PD1 and PDL1 inhibitors, such as the one that was used for our patient today, for the use in cancer treatment, have proven to be effective in slowing the progression of malignant neoplasms. However, it is important to identify the cardiac side effects and cardiotoxicity they can cause. Identifying patients who develop cardiac toxicity early in their treatment course is important and very essential in preventing reversible cardiotoxic-related mortality. This is the end of my presentation. Thank you very much.